And this is where I think we may disagree a little bit because I know you hate managed care. But if you could carve out Stark from managed care, there's no reason that you need Stark protections for things like Medicaid managed care or Medicare Advantage. Stark law does not apply to private insurance. So if you have commercial insurance, there is no Stark law because the commercial insurance has utilization control, right? You need a prior auth to get that MRI. And so the same thing happens in Medicare Advantage and Medicare MCOs. So there's really no reason for Stark law. So one of the ways that I think you could actually legitimately reform Stark law and not open the door to a ton of fraud is just carving it out of managed care. Over 50% of Medicare beneficiaries have Medicare Advantage. Over 80% of Medicaid beneficiaries have Medicaid managed care. So you could just carve out and say Stark doesn't apply if there is a private insurance intermediary. And I think that's a really good way to do it and still maintaining some sort of bulwark against fraud.
If you like your healthcare plan, you keep your healthcare plan.
Nobody knew that healthcare could be so complicated.
We finally beat Medicare.
This is the Doctor's Lounge.
Hello, we are back at the Doctor's Lounge after a week off, a much-needed break for the indefatigable Dr. DiGiorgio, who is crisscrossing the country doing seemingly everything. He's single-handedly trying to right the ship in terms of healthcare policy in America. So you needed a break because you were testifying in Congress. So congrats.
Thank you
for doing that and for making your voice heard. The testimony is fantastic. I am 100% going to link to both the YouTube link to it. We're also going to link to the written testimony that apparently I found out is a little shorter than your actual verbal testimony to Congress. But how did that go? I mean, this is not your first time. This is not your first rodeo. You're like old hat. You're doing this, right? So, but tell me, what was the experience like?
Yeah, old news, right? It's great. So I really want to give credit to the Energy and Commerce Committee, Subcommittee on Health, for having this series of hearings. So this is their third in the series, the first all around healthcare costs for Americans. So the first featured the insurance companies. The second featured pharmaceuticals. And now they're looking at what they call the provider landscape, which I know a lot of doctors don't like that word, but that encompasses hospitals, physical therapy, physicians, and all that. So I was an independent witness speaking on my own behalf, not representing any institution. The other witnesses there, David Aziz from the American Medical Association, Sean Martin for American Association for Family Practitioners. There was a representative for the American Hospital Association, the AHA, and then a representative from the healthcare buyers, so essentially the ERISA plans. And then the Democratic witness was speaking about behavioral health, largely there to talk about the cuts to Medicaid, which is sort of tangentially related to the whole topic. I thought it went very well. It gave me a chance to speak about hospital consolidation. We talked a lot about physician-owned hospitals. It seems like a lot of the at least Republican members and maybe even some of the Democrat members are a little skeptical of the continued ban on physician-owned hospitals. There was a lot of discussion on that. And all the other things that, the things we routinely mention on here, we discussed. So Stark Law, certificate of need laws. We talked about physician non-competes. We talked about the bureaucratic overload that independent physicians face, such as MIPS and all the other Medicare conditions of participation, the fact that Medicare prohibits cash-based contracting and independent contracting, all of that came up. So very productive hearing. I'm happy to talk about any part of it. There's some suggestions I gave, both in the written form and verbally. But yeah, I thought it was great. And I, really appreciate them having me.
Yeah, no, and I'm sure, you're extremely articulate in discussing health policy, and obviously you have a deep well of knowledge, so it comes out, and so you're like the perfect person to kind of represent for physicians. And
except
by the
for
way,
you,
please, your testimony is extremely broad. I am embarrassed to say that I read it. I didn't realize that the video was actually going to be that much different than this. I'm gonna have to watch the video now. But the written testimony was awesome, and you're talking about your blueprint for what to do to directionally move us in a more positive direction, right? You discussed site neutral payment, and this idea that, and it's not like Anthony DiGiorgio is an extremely bright individual, but my goodness, MedPAC has literally been saying site neutral payment forever. MedPAC is the advisory committee that exists to advise Medicare on payment and whatnot. And they've said site neutral payment over and over and over again. This idea that hospitals once you become a hospital, you suddenly get paid much more. The problem, Anthony, is that every little funding line becomes a existential threat if you cut that funding line, right? So, God, I mean, and the problem is that the health systems in all these economies, if you're talking about a small city, my goodness, it's like 80% of the health economy, 80% of the economy, right? Even in a place like Philadelphia, which is, the sixth largest city in the United States, if you went after health system revenues by just, one day tomorrow telling all the major health systems in Philadelphia that, the work you're doing right now, it's now going to be valued 30% less, it would be absolute pandemonium. And I think that probably is why there's such it's like untouchable, despite the fact that everyone knows that it's completely ridiculous. Do you get that sense? Do you get the sense that that's the big, it's not that people don't understand it. It's that touching that would be just create chaos, economic chaos.
Yeah, and you've mentioned the sort of soft landing before, and I tend to agree with you. But to counter that point, if we increase competition in the healthcare space, if the big academic centers and the big consolidated hospitals don't get these largesse from the government, there's going to be more healthcare facilities popping up. So yes, some people may lose jobs. Some physicians, I think, will have to take a pay cut or learn how to operate a private practice again, which I think in the end would come out neutral. I think the point that's worth making is that in most congressional members' districts, the largest employer is the hospital. And it's really hard for a congressperson to go against such a huge constituent, such a sympathetic constituent too.
Right. And so you cannot do just one thing on its own. You can't just do site neutral payments. You must create an avenue for alternative forms of healthcare delivery to come up, because yes,
right,
you're going to create a lot. You're going to create a lot of displacement. But if you don't also, with site neutral payment, also allow physician-owned hospitals to come up, if you don't also allow the thing that doesn't get a lot of mention, and I'm so glad you mentioned it, if you don't have Stark Law reform also happening, then you are not going to just solve the problem here, right? You cannot do site neutral payment on its own. You must have site neutral payment and allow other places to come up. And honestly, I would suggest, since it's not like you get rid of site neutral payment and tomorrow there's a hospital, right? There are some abandoned hospitals that maybe you could, private capital would come in, take over, and do something with. Perhaps there's those. But I would suggest the first thing you need to do is to massively increase the amount of competition there is in the current landscape, right? Though it presents problems, right? Because if you bring on physician-owned hospitals that then become reliant on the gap in payment between ASCs and whatever, now all of a sudden you're now going to have the physician-owned hospitals that are going to be lobbying hard to keep site differential payment systems. Compromise, again, sorry my physician colleagues, don't throw tomatoes at me when you see me next time, but a great compromise I think would be, look, we're going to allow physician-owned hospitals, but we're going to pay those physician-owned hospitals at the rates of ASCs or whatnot.
So MedPAC in their report actually has a methodology for site neutrality that doesn't involve just bringing everything down to the physician fee schedule.
Right. It's
facility fee rates. It basically, you take where the service most commonly is performed and bringing the facility fee to around there. So one example they give, and this is all in my testimony, but a echocardiogram, this is up your lane, is 194% more in a hospital than a freestanding office. So if you implement site neutrality tomorrow and don't even, say you bring it close to what the physician fee schedule facility fee is, now Coca Cardiology can expand, right? You're probably going to hire an echo tech because there's going to be this need. People are going to want to be getting echocardiograms. The hospital's no longer going to want to siphon all of them into their inpatient facility because they're not getting that huge largesse anymore. So I think it'll all come out in the wash in terms of job creation, but overall the patient is going to have, and the employer that's paying the bill is going to have more money to do other things with. So the economy will grow in other ways. There's a great paper by, I believe, Brock Goldberg is the first author, that shows that consolidation decreases the local economy, the strength of the local economy, and leads to job loss because businesses are the ones that ultimately have to pay for these higher prices with consolidation. They give some percentages, but you get job loss, you get economic stagnation, and you actually get a decrease in tax revenue because you have a nonprofit that's consolidating and charging higher prices, you don't get to tax those higher prices on the nonprofit, but the lack of economic activity decreases local tax revenue. So I think economically, this would be a painful Band-Aid to tear off. I agree with you there. But ultimately, it will be more successful for the local economy. There will be more jobs. There will be plenty of jobs still in healthcare. There'll be more competition, and there'll be more money for non-healthcare entities to then use to expand their businesses.
Yeah, no, absolutely, and that's a great point that, like you said, you did bring up in your testimony in terms of this. I mean, the folks in MedPAC are not, having read some of those MedPAC reports, they're pretty bright individuals that have a deep understanding of what's going on, and it seems over and over again, the problem with our government is not that there are not people there that understand. There are people that understand what the real problems are. It's that there's so much of people's income that's tied into creeping things this way. That's what creates this massive amount of paralysis. Without getting, citizens to be more informed and understanding some of these issues, I think you're not going to get. I think it's going to be hard to break through this kind of impasse that's created. The other, we talked about site deployment. We talked about physician-owned hospitals. Obviously, we want more competition. Talk to me about Stark Law. And I mean, this is my favorite one that's often ignored. But anyone who goes in private practice automatically understands this, right? And I think, interestingly enough, I see a lot of physicians who are like-minded, like us, independent, who actually want Stark Law implementation to be applied to the hospital systems. And I actually think the opposite. Tell me, Dr. Giorgio, your thoughts.
I agree. And so for our listeners who don't know, Stark Law is essentially a self-referral ban in Medicare. And the reason it's implemented is when it was Medicare fee-for-service, there was essentially no utilization control, right? So I, as a neurosurgeon, if I was in private practice, could purchase my own MRI machine, send all my patients for weekly MRIs, because I think that now that I own this machine, I want to bill Medicare for a weekly MRI on this brain tumor patient, which is completely unindicated. So there was a good reason for this initially. In Medicare fee-for-service, there's no utilization control. So Stark Law essentially made it so that you cannot refer as a physician to things that you own and get a volume as the way I think of it is you can't get a volume-based reimbursement for that. And correct me if I'm wrong, because I know there are ways that physicians can, as groups, own things like MRI scanners, physical therapy. But it's a lot more complicated. And one of our colleagues has mentioned that he was trying to expand his independent spine practice and purchase an MRI. He got 3 lawyers to come together, and they gave him 5 different opinions on how to go about navigating Stark Law. So it's one of those things that if a hospital system wants to come after you, if the government wants to come after you, they'll probably find some way that you violated Stark Law and had referred to yourself. So instead of just eliminating Stark Law, because I think that, with all the fraud that we're seeing, there is clearly a avenue for fraud in Medicare and Medicaid. So we do need some fraud protections, especially in fee-for-service billing. And it's really important to note the lack of utilization control in fee-for-service. I bring it up a couple of times because it's important that in fee-for-service, if you're billing the government, you can just submit a bill and they're supposed to pay you for it, right? So you get an MRI, the government's just supposed to pay you for it. And this is where I think we may disagree a little bit because I know you hate managed care. But if you could carve out Stark from managed care, there's no reason that you need Stark protections for things like Medicaid managed care or Medicare Advantage. Stark Law does not apply to private insurance. So if you have commercial insurance, there is no Stark Law because the commercial insurance has utilization control, right? You need a prior auth to get that MRI. And so the same thing happens in Medicare Advantage and Medicare MCOs. So there's really no reason for Stark Law. So one of the ways that I think you could actually legitimately reform Stark Law and not open the door to a ton of fraud is just carving it out of managed care. Over 50% of Medicare beneficiaries have Medicare Advantage. Over 80% of Medicaid beneficiaries have Medicaid managed care. So you could just carve out and say Stark doesn't apply if there is a private insurance intermediary. And I think that's a really good way to do it and still maintaining some sort of bulwark against fraud.
Yeah, right. With all the stuff that we've seen recently with Medicaid fraud and the intrepid Nick Shirley that has now made his way over to the People's Republic of California, your neck of the woods. Did you watch that video of his recently?
The Los Angeles Hospice one?
Yeah. That one?
And so part of the reason, so I think that's worth talking about in this discussion because those hospices they're not subject to any of the same rules that we as doctors have, right? So there was this huge thing when doctors were billing Medicare fee-for-service that all the doctors were greedy and inherently suspect. And so they created this Stark Law, which puts these handcuffs on doctors. But apparently anyone can go to Los Angeles and open a hospice facility and just self-refer. And there's no restrictions on that.
Yeah, this kid, Nick Shirley, I don't know, he's like 15 or 16 years old or something. he shows up in this parking lot motel, and the parking lot is full of like Maybachs, and is that a car? Maybach? Apparently it's a nice car. Like
he's 23, by the way.
Okay, 23.
I just looked it up.
Sorry. High-end Beamers and whatnot, and he starts knocking on these doors that have like names of hospice, motel, like it's a motel. And he goes to each motel and he's like, "Hello, is anyone there? I'm looking for this hospice thing." And then suddenly, out of nowhere, I'm gonna get the nationality wrong, and Armenian, I think Armenian person, heavily accented,
yes.
Armenian individual comes out and starts following him around. I don't know why, and then essentially tries to chase him away. And of course, this is on the heels of Oz showing up at some point in California and claiming that there's a bunch of Armenian gangs that are committing hospice fraud and funneling money. Oh my God. I think this is insanity. So yeah, you're completely right about the fact that clearly we need some type of brakes on the system. But it also does make the point, right, that why is the system so focused on physicians defrauding the system? Because, physicians, of course, have defrauded the system, and physicians are, of course, have been responsible for waste and abuse. But, the thing that is somewhat stopping physicians beyond our oath that we take, and we're supposedly a highly filtered class of people that get through whatever hurdles to get an MD. But beyond that, we have a license that we have to maintain, right? And every physician I know is terrified of something happening to their license, right? And so there is that kind of, number one, the average physician is not excited to lose their medical license, because the medical license is literally what allows you to, be and practice and do what you do. You cannot really practice medicine without a medical license. And then, on top of that, there's a healthy fear, because doctors live relatively comfortable lives in whatever suburbs and we live in, of going to jail, right? Meaning you don't want to get on the wrong side. Now, I imagine, somebody who's a criminal, who doesn't have a medical license, who has been in and out of jail for, I don't know, some number of years for some variety of things. There's, what's to stop him from being like, oh, there's this game where I can get a hospice and I can set it up and then buy a bunch of Medicare numbers and then start billing and getting paid. Okay, so they catch me and I go to jail. The whole thing strikes me as hilarious. It's they're so worried about physicians and the fraud that we're going to commit because we're conflicted, and they're not. It's okay, you're not at all worried about, of course we talk all the time about nonprofit health systems and the CEOs and advertising in Citizens Bank Park or whatever major ballpark you have, right? And they're literally just serving as these, highly corporatized versions of, where profit is the key thing. There's that. And then there's the other end of the spectrum, which is being exposed now by kids like Nick Shirley on how are you preventing fraud from the other rungs of society beyond physicians? And arguably, again, I'm going to say it again, that there's a bunch of things that are kind of beyond the ethics of supposedly physicians. Say all physicians have no ethics. Beyond that, most physicians are terrified of losing their license. What is preventing Armenian gang member? What's preventing him from doing that? Right?
Yeah, it's worth noting Nick Shirley was the one who also uncovered the Medicaid autism fraud in Minnesota. And it really is the fact that you can bill the government for these services with very little utilization management is what it comes down to. And that's what was happening in these autism centers. You saw some places don't have a cap on how much you can bill Medicaid for teaching facilities, learning facilities for autism patients in Medicaid. And so you could sign up 20 kids, charge them $800 an hour each, and just bill Medicaid for that. And there was no utilization control because, again, when you're in this fee-for-service environment, all you do is submit the bill. The ICD code matches the bill, the CPT code, they send you a check. There's no third-party intermediary. And that's where I don't like a lot about Medicare Advantage and Medicaid managed care, but that is one thing I think that they can provide as a bulwark against some of this fraud.
Yeah, no, absolutely. So I guess it's always such a struggle. How do you that's why it gets back to this original, what's the original sin thing? We always talk about this, and the original sin is, of course, third-party payment. But yeah, you're 100% right. I can't disagree with you. If you have a third-party payment system like we have now with Medicaid, Medicare, that's just sending money for claims they receive, then yes, of course, you're going to need some type of check on utilization, right? So whether that be, whether that be prior authorization or something smarter than that, I'm not sure what is. I mean, Dutch has talked about, different systems where you don't have prior authorization. I mean, I struggle to quite understand how exactly one implements things where when you have
narrow
this
network with gold carding, I think there's other ways to that
right.
payers can ensure they're getting quality. But yeah, there's multiple ways to do it without the onerous prior auth method.
Right. Yeah, correct. Well, anyway, so again, but I think the point to come back to here is that Star Clause, what it does is it prevents referrals, right? And so a physician can't own, it's to prevent exactly what you're talking about in terms of the MRI, and it applies to everything. Like physician in terms of owning their own physical therapy or owning, you can't have relationships with other groups where you're getting any type of monetary kickback or amount back for making that referral, which again one understands, but by the same token, there are ways around it which the health systems have figured out. The health systems simply employ people and they pay folks some type of overage over whatever, and some of that is dependent on what their type of downstream revenue referral is. And if you're too explicit about it, right, if you do it in a way that's not explicit, everything's okay, everything's kosher, right? But if you're too explicit about it and you upset somebody, and somebody goes and whistle blows to the government, people get in trouble, because that is what is fundamentally happening. Health systems are not paying a premium for you or whoever it is unless you are doing something of value, and that value frequently is the amount of procedures you do, the amount of referrals you generate. So we have a very asymmetric system that's kind of exists. I think one approach to, we keep talking about soft landings, at least I do, is one approach to trying to come after these large academic health systems really is to allow that increased competition with physician-owned hospitals by taking out Star Clause, to allow kind of integrated referral networks to exist. Yes, sorry, that physicians may profit off of that, but that is a fantastic bulwark against what's happening right now, which is basically handing over monopoly power to a large health system, right? So allow these independent physician groups that are scattered about surrounding these health systems to kind of get together to be able to kind of push back even more effectively against the health systems, which right now are like the only place to get certain types of certain levels of care or whatnot. So if you allowed physician-owned hospitals, you allowed independent physicians to kind of string together to do stuff and not be forced to be under one EIN number, right? Because that's right now, that's what has happened. In order for me to get together with 7 of my physician colleagues around the Philadelphia area, right, and also send patients to an ambulatory surgical center that we perhaps co-own or something, or have some type of financial relation to, right now that would be illegal. Cannot do that, right? And so it doesn't happen, right? The health system has no problem with any of that. They just own everything, and and that's what happens. And so they are the only game in town. So if you want to get procedure X, Y, and Z and you end up at some health system, you are going to get some massive charge, right? So the only way to push back against that, my fellow Americans, is to allow competing interests to come up. And if you have the type of competition, you will, in the way that, Dr. DiGiorgio, and the way, Anthony, that you're kind of framing it, I think you will not have costs that just keep skyrocketing, and you will have a better kind of solution here that works for patients and employers who are ultimately footing these insane bills.
Yeah, and I spoke specifically on this in my testimony, if you allow me to quote myself.
Yeah.
6001, which the physician and hospital ban is, start creating an untenable double standard where corporate health systems are granted broad safe harbors that allow them to functionally pay primary care doctors for lucrative downstream referrals simply by employing them. And then I cite a study that shows that when hospitals acquire independent primary care doctors, they anti-competitively steer referrals within their own system. Ironically, this paper was written by David Cutler, who was one of the architects of the Affordable Care Act. So the independent physician, especially the primary care doctor, is more valuable to the health system than they are to themselves, right? If you're an owner of a primary care practice, a health system can extract more value, because if they were to purchase your practice, all of a sudden, all the clinic visits now carry a facility fee. So just the simple arbitrage on billing all your clinic visits goes up about 100%. So you double the revenue just from there. And now the health system captures all the referrals from that practice, all the specialists, all the surgeries, all the MRIs, all the physical therapy, all the labs, everything goes through the health system. So that independent practice, that is why the big hospitals can buy these independent practices. If that independent practice tries to stay independent, they don't get any of that financial arbitrage that comes with the facility fees and the referrals. And they get constantly beat down with more Medicare bureaucracy, less Medicare payments on the fee-for-service side. And so it creates this imbalance that is impossible for these independent practices to overcome. And that's why we see all this consolidation.
Right. No, that is 100% correct.
It just, ironically, the Federation of American Hospitals had a fantastic tweet after that hearing where they said there's no issue with physician-led hospitals. The issue is about the conflict of interest when physicians self-refer patients to their own hospitals. Data is clear. POHs tend to treat more commercially insured and healthier patients than full-service hospitals. They got ratioed so hard on that tweet. It's currently sitting at 95,000 views and only 20 people have liked it. Because everyone knows, every physician that works in a hospital knows that hospitals are guilty of the exact same thing. Yet the hospitals are allowed to self-refer and physicians are not. Somehow the hospitals are immune to this corporate greed that physicians have, and their self-referrals must always be altruistic, whereas a physician will only do it out of financial self-interest and to harm their patients. It's just ridiculous that the Federation would come out and say this, because any doctor, I think even most patients probably realize that this is happening on the hospital side.
Yeah, no, it's really ridiculous. There must not be enough hospital administrators on Twitter or something, or I don't even know. And
just a nice historical fact is the lobbyist for the Federation of American Hospitals, it was the main architect of Section 6001 of the Affordable Care Act, which banned physician-owned hospitals. So there was actually what was called a whole hospital exemption within Stark Law, where if the physicians owned the hospital, the whole hospital was exempt from Stark, because otherwise it would have been self-referral. And so really what Section 6001 did was just expand Stark to prevent self-referral to the whole hospital. And again, the architect of that was one of the lobbyists for the Federation of American Hospitals.
Yeah, it's just, it goes to show you how important it is for physicians to be involved in this type of stuff. Because if you're not involved and you just blindly trust, like me, our health policy elite to come up with beautiful solutions, you get stuff like this, which it's like, I cannot believe. I can't believe. I can't believe that was in and it passed and everyone cheered, and it's because most people just didn't know, and most people still don't know. Like, I would love to hear physicians explain to me. Go ahead, tell me why physicians are banned from owning hospitals. That is the most insane thing. I think one of the most insane pieces of health policy legislation that has come across. All right. We're going to talk about your testimony for many Doctor's Lounge episodes to come. We should probably spend one whole episode talking about your testimony. It's so good.
It wasn't that good. Yeah. We'll link to it. People can judge for themselves.
No, it was extremely good. I'm going to actually link to it right now on one of our tweets while we're talking. So at HHS, Secretary Kennedy and Dr. Oz announced today a new healthcare advisory committee, top experts from across the country, coming together to provide insight on how to cut costs, reduce red tape, and put patients first. Dr. DiGiorgio, I was sad to see your name was not there. What the heck?
That's okay.
Who is on this thing? If it's not,
I've got enough other things going on. There are some good names on there. I had the announcement pulled up. I don't know. What are your thoughts? Do you think this will move the needle at all, or is it going to just come out with some recommendations?
Yeah, I don't know. I don't know if is it a play. Look, I don't understand the political game. I mean, folks like Donald Trump and Kamala Harris. Well, maybe not Kamala Harris, but folks like Donald Trump are extremely savvy at politics, right? And things that seem completely wacky, and he ends up. I mean, whatever you want to say about President Trump, I mean, the man is president after playing politics, and so the political game is always so difficult to kind of read and figure out. I think this idea that you can go to Washington D.C. and just do the right thing and everything will be fine, like, it just doesn't work. Like, as we saw with our buddy Vinay Prasad, the guy was like, he was like a Tomahawk cruise missile doing the right thing, I thought, but you have to pay attention to all the politics of how things look and stuff. So anyway, long story short, long-winded answer, but if it's some play to get a bunch of good good people behind real good solutions, and that somehow improves the chances of getting good legislation through, great. But I think everyone knows what the problem is and how to reduce costs, right? I mean, we talk about it every day. I mean, it's almost like, what is the point of having this show? We could finish it in five episodes because we just repeat the same thing over and over and over again. Everyone knows what the problem is. The question is, like, Tony Robbins. And Tony Robbins is on there. I mean, apparently he's a tremendous motivational speaker. And hey, fine. If you can maybe if Tony Robbins was saying we should repeal physician hospital bans, maybe then we'll get legislation. So maybe.
How much do you think Tony Robbins?
You know, I hear that he is an avid listener of Dr. DiGiorgio. I think, he apparently follows you or something. No.
That would be surprising.
Yeah.
I mean, the charge of this committee is admirable.
Yeah.
Defend actionable policy solutions to better manage chronic disease. Who doesn't like that? Advance accountability for safety and outcomes. Expand the use of real-time data to support higher quality of care. Speed up claims processing and improve quality measurement.
Yeah. Enhance
care for Medicaid patients and strengthen Medicare Advantage sustainability, including risk adjustment and quality measurement. I mean, those are all admirable tasks. I will be hopeful.
I don't know.
Maybe I'm insane because I remain hopeful.
When I hear improving Medicare adjustment risk, I'm like, oh man, like you're trying to this is like the sunk cost policy. Look, I get it. You need some type of utilization review for Medicare traditional FFS, traditional fee for service. As much as I like traditional fee for service with a supplemental G plan, I mean, I love it. It's great. You know, there's not a lot of back and forth, right?
You didn't get the efficiency cut this year.
Right. Correct. No, it's not. You're right. So, my MIP score, I'm working on it, making sure I'm checking all my boxes to make sure I don't get these cuts. But I mean, that's the other thing with this whole MIP score BS, right? Sorry, as an aside, like this MIP score, like what? Like just any independent physician who's working for like 1/4 the amount of my hospital employed colleague down the block, I'm like automatically more efficient. I would have to do 4x the number of echoes in order to be less cost efficient than my guy down the street. So look, I can make your MIPS thing really easy. If you're an independent physician, you just automatically get a bonus. All right, how about that? That would be my thing. Anyway, look, to me, sometimes it feels like we're just throwing good money after bad in some sense. Like improving Medicare Advantage risk readjustment. Like how do we improve Medicare Advantage? How do we? As you said, there are different ways of doing it, but I mean, it's so complicated, Anthony. Then you have to mandate Medicare Advantage, do something a certain way in terms of say you have a gold card for prior author stuff, or instead of that, right? Or I mean, there are smart ways to do it, but it makes my head hurt to think about how to do it. And then you're depending on some bureaucrat to get something correct, and it's like every system is going to be gamed so that some insurance company is going to be making $1 bajillion. So I don't know.
I think I think there might be some good points there. We both agree from first principles that it's hard for the government to run and operate a health plan.
Yeah.
But we're in a world where the government is insisting on running and operating a health plan. And so if it's going to do that, I think that having a third-party intermediary is probably better for waste, fraud, and abuse. So how can you do that? And are there ways to modernize Medicare so it at least is not as bad as it was before? And I think, so right now, for those that don't know, Medicare gets paid based on how sick their patients are, right? And so it determines how sick their patients are because you want these plans to get more money for signing up sicker patients, or else they're going to just cherry pick healthy patients. And so now there is a financial incentive for these companies to make their patients seem as sick as possible. And so what they'll do is there's actually these insurance companies will send people to nurses and doctors to people's homes and find every last diagnosis that they could put in the chart to bump up their risk score and get more money. And there's actually a large return on investment in that. And so I think, if we're going to insist on having Medicare run its own health plan, you can make that process not as bad. I don't think you can ever make it perfect from a first principle standpoint that you and I would agree with, but you can at least make it so the hospitals don't, or the insurance companies don't have this huge ROI on just sending people out to put diabetic retinopathy in the chart so they get paid more.
Yeah.
You can make it auto extract from objective data using AI. I think you could do a lot of different ways to better calculate the ground's truth of how unhealthy the patients are. You'll never get, again, concede the fact that it will not get to something that you and I think is perfect, but it could be a little less bad than it is now.
Yeah, no question. Anything that's less bad is a good thing. I think we need to kind of, we need to understand that, and Milton Friedman, I say this all the time. Milton Friedman, when you listen to him enough, he all the time would, when you'd have these conversations, talk about, okay, this is where we need to get to, and what is pragmatic. And he would look to the politicians, like the folks, well-versed politicians, like, and he's such a brilliant guy. And he would pause and say, wouldn't that in that friendly voice of that big smile, wouldn't that be possible? And as if he's asking, he's like, this is what we should do, but is that possible from a political standpoint, or where we are and what the politics say? Next topic, not to get spicy, but there's
you want to get spicy.
Well, yeah, there's this issue that's raised over and over again. We're gonna beat around the bush a little bit. There's this issue that's raised all the time, right? The rural access gap. What do you think about the difficulty our rural poor citizens in the United States? Like, what is the scope of that problem, and what should we do about it?
I don't know, because part of it is, what do you define as rural, right? I think that's one of the main issues is, Stinson Beach, California, down the street from me, is considered rural. It's a 30-minute drive from San Francisco. So I think that's part of it, is you end up, you lump a lot of these hospitals in, and they get classified as rural, and maybe they're not. There's no question that if you're living out in the middle of, I don't know, Texas, 4 hours from the nearest town, you're probably not going to have great access to healthcare. If you're living in Houston, you're probably going to have better access to healthcare than anyone else. There's some comfortable medium there where you can get people, but not everyone's going to have the best open aneurysm surgeon on the planet within a drive away. 99% of the country doesn't have that, right? So I don't know. I think you could probably want to set some sort of baseline. And this is where I actually think that it is more of a community good. Healthcare readiness is a community good, like the way we treat firefighter readiness, right? So you would pay, a local community could pay to have 24/7 trauma coverage, heart attack coverage, stroke coverage, OB coverage, just the way that they pay for 24/7 fire and police. I think that is a totally legitimate use of a community good and public funding. I think it's silly that we pay for trauma and stroke on a fee-for-service basis when you really should be funding it for a readiness basis. You don't pay firefighters depending on how many fires they put out. So that's how I would encourage localities to do it. If you ask the federal government to make these large programs, you end up losing local control. I would do grants to local communities so they could do it locally, and that way you can have more focused services. But I don't know. What are your thoughts?
Well, yeah, I mean, I guess what I'm going to bring up is that I feel like the plight of our rural poor, which, as you very nicely said, and I'm glad you brought it up because I was going to bring it up if you didn't bring it up, was the fact that there's way too many folks that are labeled. If you're 30 minutes away from a major teaching hospital, okay, I'm sorry, you may be defined as rural poor, but that is probably as good as you're going to get. That's probably that's probably the best you get in the world, okay? I don't know that we're going to get too much better than being 30 miles or 30 minutes or something like that from there. 30 miles, okay, in rush hour, it's an hour. Look, that is not bad, okay? So if you do have some baseline things in terms of defining, and then go about saying, okay, what percentage of the population is truly rural poor? I think you're talking about a very, very small percentage of the population, all right? If you define it that way, right? This idea, like you said, that's completely inane, utopic, I'll go as far to say asinine, that, you need like a UCSF style center in Topeka, Kansas. Is Topeka a big city? I don't know. Maybe Topeka has some great thing. I don't know. But anyway, my point is some Tubaluk, Montana. I'll make up some name. That's not to get anyone in trouble. Not to get myself in trouble. But the point is, you can't have that in every single place. You may have to drive to that. Right? It doesn't work.
Topeka, Kansas has 125,000 people.
Okay, all right. So relatively small. It's okay. So they probably don't have the most. Anyway, I'll stop there.
We just lost all our Topeka listeners.
All Topeka listeners, yes. I love Topeka. I've never been, but I hear they have great steaks. But where was I? Yeah, so right. But then that tiny percentage of the population that actually is, difficult to get to, has difficult access and stuff, they are being weaponized for all sorts of policy proposals that I don't think are in the best interests of everyone. I really don't.
Just quick stats that I looked up. I had some of it handy. 81% of the U.S. population lives within 1 hour of a level 1 or 2 trauma center.
I mean, that's pretty good.
That is almost the entire population.
Right.
It's hard, given the geographic breadth of this country, it's probably hard to do much better than that. And I'm sure if you include level 3s, you're probably getting close to 99.
90%. Yeah, exactly. So, it's weaponized all the time. So it was weaponized in the 1980 whatever bill that Bill Clinton passed, and that's kind of why, that was the big push for why nurse practitioners were given independent practice, right? Again, I'm not philosophically opposed to anyone wanting to practice medicine if they want. I think physicians have a ton of training. You want to open up a practice and start trying to practice, neurosurgery or oncology or cardiology next door to me, please be my guest. I suspect I'm going to do okay, and I'll be fine. But this idea that nurse practitioners giving them the ability to practice independently, that was going to be the solution to solving the rural shortage problem. That didn't happen. That's been 20 some years, because all the nurse practitioners, there are some wonderful, lovely nurse practitioners who do set up shop in areas that nobody wants to go to, no physicians want to go to. And that happens, but that is rare. The vast majority of folks that are becoming nurse practitioners are doing it because they want to do X, Y, and Z in some major city, which is just a natural human thing. Most people want to be in cities, which is why most people are in cities. And so, you kind of created this NP path to allow NPs to practice independently so that you would solve the rural poor problem in terms of access to medicine, and you have not solved that at all right? And by the way, you've probably devalued family medicine, etc. You've probably allowed, the widgetization of the American physician, right? Where now health systems are like, oh, look at that. We just have somebody else that can refer for 10 downstream revenue producing procedures. I don't care what type of provider it is. It could be an NP, could be an MD, could be a PA, could be a ND, whatever, right? Like tomorrow, if the government said, we're going to allow naturopaths and crystal healers to bill Medicare, 100% the next week, there would be naturopaths and crystal healers in health systems, because, hey, they're much cheaper and they can do kind of the same job, because all the health systems care about is that downstream referral. They don't really care about quality as much as they say they care about quality. So
to push back on that point, though, if you could charge Medicare for crystal healing, the crystal healing industry probably would hate that, because then you can no longer charge cash. And right now they would rather take cash with no third-party intermediary. That's why the dentists have held out from being in Medicare.
That's a very good point. But of course, Medicare for crystal healing would pay so little that nobody would participate. They would still be out network.
Right. That's true. Like acupuncture is covered here in California for Medicaid. Right. You can't find a Medicaid participating acupuncture provider. Right. It's very difficult.
Yeah, it's like psychiatry. Like, good luck finding a Medicare participating in psychiatry. So, of course, the latest round of folks that constantly bring up the rural poor is international. Is the debate on international medical graduates, which I think is a nuanced debate that we should probably spend some time on and maybe get a guest in on. But I'll just say, the only thing I'm going to say about the IMG thing is that this idea that we're going to solve the rural poor problem by a constant inflow of international medical grads or importing even more international medical grads is complete fiction. I mean, the vast majority of international medical grads have no interest. Like, the guy who trained in Delhi has little interest in continuing to practice in some rural place in Montana for the rest of his career. Now, he may end up practicing there for the rest of his career because he ends up being forced to, because he can't get somewhere else for whatever reason. But the vast majority of international medical grads have no interest in practicing in rural poor America. So, so they're max going to stay for their J1 visa, they're going to stay for their 3 to 5 year amount of time they have to do there, and then they're going to move on. So this is not a good long-term solution if that's what the problem is. And I don't know that the problem is so massive that we have to necessarily upend a bunch of different things. So my bigger issue, which it jives with what we talk about all the time, is the fact that there are members of the local community in many of these places that would absolutely serve as practitioners, right? And we should have accelerated pathways. Like, if you are a bright kid in a rural part of the country, okay, like, we should bend over backwards to get you to be able to practice medicine. Yeah, like 150%, because that kid is going to be 90 times more likely to want to practice there. Now, of course, there's going to be some of those kids that are going to be like, hey, get me the hell out of wherever I am. I want to get to the big city and stuff. That's fine. But like, what the percentage chance that like a kid that grew up in some community wants to practice in that area is much, much higher. And I think the really interesting parallel is to what happened with PCOM, which is the Physicians College of Osteopathic Medicine in Philadelphia, right? It was, this is the whole, we're well past that now, right? Where, there's the whole DO versus MD, and DO schools were coming up, and they were alternative, and they were outside the system and whatnot, and they were gaining legitimacy. And the DO track was a very different track, especially for family medicine. It was, 4 years of med school. It was slightly different, though, first 2 years I think are very, very, very similar, and slightly different in terms of the clinical years, some osteopathic manipulation and stuff. But at the end of the day, then they had a 1 year track where you could do like a residency type training, and then you were, you're out. You could do family medicine, right? And what do you know? Like, if you look in South Philadelphia, like that South Philadelphia landscape to this day is dotted with a tremendous number of DOs who were local members, boys and girls from the community, that went to PCOM, did their thing, and came back to South Philly, set up shop. They're in one of those row homes, right? I go to one of those row homes on a Saturday once a month to see some cardiology patients there in one of those offices, and that's what happened. And so I think that's a much, much better solution than expecting a kid from Hyderabad or Gurgaon, India, to like come to whatever town in the US, and he's going to set up shop and practice there for like the next 40-50 years. Like, I just think it's silly that's the reason given.
I think there's two issues. One is, when I spoke to earlier, is access to emergency services, which needs to be, I think, ideally funded like we fund firefighters. But I think what you're talking about is access to a lot of elective services, which, first principles, we should just allow the prices to rise. The problem is you can't charge more if you're the only physician in town if you're taking all Medicaid patients. If we allow prices to rise, stuff costs more in rural areas. Your broadband internet costs more. Your groceries probably cost more because they have to ship them farther. Things just cost more when it's isolated. And so it's not that you want to charge the rural poor more because you don't like them, but allowing the prices to rise signals a lack of supply. And so some kid from that community would say, hey, I could be the only doctor in this town. I could have a complete capture of everyone in this town for elective care and go and make a killing if I'm allowed to charge what I want. The problem is you're not. You have to abide by Medicaid and Medicare conditions of participation, and you have to bill E&M codes, and you only get reimbursed what you get reimbursed. But if you allowed the prices to rise, then people would be happy to go do that. And probably a lot of them would see a fair number of charity care because they would carve out, like you do, go one day a month and go to just see people who can't afford care and give free care. But we don't allow that anymore. Make it so the only way you can survive is going and billing Medicaid and Medicare, which doesn't cover your overhead. And so why would you want to do that? So like you said, people try to get international graduates to go there. They don't want to go there. Nurse practitioners don't want to go there. There's a great study showing that when they've given nurse practitioners independent rights, what they do is they end up practicing like dermatology in large cities. They don't go to the rural areas and practice family care. So I really think if you just allow prices to rise, then the market would sort itself out, and you would get people establishing clinics and stuff in these areas. The trauma care, the OB, stuff like that, you're going to have to fund that as a community good. There's no question there. But I think you could get primary care clinics in a lot of these areas.
Yeah, and these places, you wouldn't even have to say that, Anthony. Obviously, I think like in some of these places, Medicaid rates are so, absurdly ridiculous. I think you would have...
Right. You can never meet overhead.
These folks would just open up a practice and do it the old way when you didn't have it. They would just collect money from folks, right? And then they would live outside of the insurance network because that would probably be an easier subscription model or something. Like, allow those type of things to happen. And if anything, we should from a public policy standpoint, as you've said frequently in the past, is allow Medicaid, Medicare to kind of feed into some of those subscription models for certain folks that really do, certainly for Medicaid, for once you fall below whatever level, okay, great, we should feed that. But then yes, everything else, there's no reason that because those things would help, right? If you allowed a physician to practice in a rural, poor part of the country and allowed him to both take Medicaid type of subscription services on a monthly basis, plus allowed him to, for folks that allowed him to cash pay as well, then you would automatically help that in much more so than the current systems.
Right. And don't make him do MIPS, and don't make him do Medicare because of participation. Don't make him abide by Stark law. Let him buy his own X-ray machine, his own MRI. Then also, local governments are creative. They could give tax incentives for local physicians to set up shop. They could even, you could probably get a local community to fund a subscription type service where, $2 for every person per month, in the community, as long as you see them when they want. And there's so many different ways that you can do these creative finance. And this, going back to my testimony, is that I brought up is that Medicare conditions of participation restrict physicians from coming up with these creative ways to finance care because you can't charge cash prices. You can't enter independent value-based contracts with local businesses, right? You have to abide by the E&M, the physician fee schedules with E&M codes, the CPTs, and RVUs. So you can't enter all these creative ways to pay for it that I think would really unleash competition in the free market if you allowed physicians to do that.
Right. No, absolutely. Absolutely. Yeah. No, we have to think about who we can bring on to talk about it. Our friend Dr. Bowden has been in the news quite. She's been making many waves on this front. So we'll have to think about who to.
Well, I think Josh Umber with Atlas MD. I mean, I'm sure he's got a large rural footprint, and again, a lot of this is going to be regulated on a state by state basis. The way some states try to address this is with their state directed payment programs. Where you can essentially give a supplement through Medicaid payments if you go to certain communities. But again, it's a lot of central planning. It's on a state-based level, not on the community level, and it just ends up being manipulated by a lot of these large health systems. I think the FQHCs and critical access hospitals are kind of a good example of what can go wrong there.
Right. No. Yeah. Absolutely. Well, we're nearing an hour, sir. Anything else that you want to talk about?
No, I think one of the last things I did bring up in my testimony that I think is worth talking about is something we came up with about a adjustment to the federal matching rate for Medicaid based on a state's competitiveness. So this, going back to the Medicaid talk, is the federal government reimburses between 60 and 90% of the Medicaid costs for the states. But a lot of these states are driving up the costs with things like certificate of need laws or restrictive covenants for physicians. And so the federal government, if they're footing a lot of the bill, I think should be able to tell the state, like, look, if you have certificate of need laws, we're going to drop how much we're reimbursing you because you're artificially inflating the cost of care in your state. And we're not going to, it's not fair for a competitive state to fund a non-competitive state that's driving up the cost of care. So I think that was just one other thing that is worth mentioning. There seemed to be some buy-in from some of the members there, which I think would be a good project to undertake.
What was obviously you're testifying in front of Republicans and Democrats.
This is true.
How did that go? Like, did you get a lot of questions from both sides, or what can you talk about? I should have. Sorry, I'm a bad interviewer. I should have talked more about that.
No, it's okay. The Democrats didn't want to talk to me. They used most of their time just to basically do stump speeches. They used it as grandstanding time to talk about the One Big Beautiful Bill and the lack of extension of the supplemental ACA payments. Those were the two things that they brought up over and over again. They really didn't ask that many questions. They direct a lot of the questions at the Democrat witness and the AHA, just asking what service lines are going to be closed with fewer Medicaid funds. And so the Democrats really didn't want to engage that much with me. I don't think I got a single question from them. They were listening, though. AOC was there for part of the hearing. She listened intently to my opening statement, and then but did not stay around for questions. I was looking forward to getting a question or two from her, but it did not happen. But I think the Republicans were very engaged. I was very impressed. There's a lot of physicians in that committee, so Representative Miller Meeks, Representative Joyce, to name a few. Their physicians had very good questions, very much interested in physician-owned hospitals. So a lot of good engagement from that side.
That's disappointing. It's too bad we can't. Is there anything that you think that would get Democrats interested in some of the proposals? Like, why wouldn't they be interested in breaking the hospital system kind of monopoly? Like, they seem very intent on what are they? What do you think the political game is from their side?
I think they are sympathetic to the monopoly idea. And one of the points I did bring up is there's good data showing that the allied health and nurses' wages go down when systems consolidate. So you have a labor force issue as well, right? If you're a monopoly buyer of labor, then you're going to charge less for it's something like 7% when hospitals merge. It's like a 7% drop in nursing wages. So it's not insignificant. So I think they could be sympathetic to that, but I think politics is politics. midterms are coming up, that they think that they can win on the ACA subsidies and they can win on Medicaid cuts. And that's the point they're going to keep driving home. And I don't think they're not going to get any support from the Republicans aren't going to get much support from the Dems on any sort of healthcare reform as long as they can keep hammering home those points. They certainly don't want to give the Republicans a win before the midterms.
Yeah, it seems like things are. It doesn't seem that there's any room for coming together, because it's like the two part. I mean, like, you cannot be for Medicaid expansion, and you're not even talking Medicaid expansion. You're talking about like reducing the amount of Medicaid expansion over the next 10 years, right? I mean, if the Republican proposal is to reduce it by $800 billion over 10 years, $80 billion per year in a program that's almost $1 trillion a year, right? And that causes these crazy cavalcades about, oh my God, the world is
histrionics, yes.
It just seems...
How many people did Schumer say was going to die because of this? It was a lot.
Right, it was a lot. I mean, has that already happened? Or are people dying everywhere now? Or what's going on? Is that
you haven't seen the bodies outside
right?
your house?
Yeah, he said how many? Well, the study said 55,000 people or something. Right. But it seems like it is impossible. So I wish there was someone on that side that would. I mean, the only person that seems to be somewhat reasonable, but I don't know what his views are on healthcare, is Fetterman. But he seems to every now and then say something the Republicans say. Anyway, I don't know. It seems a very, very difficult path forward if one is looking for some type of, it's like everything that is going to have to be passed on a pure Republican-only vote. You can't.
I mean, I would love to see the days of old-fashioned sausage. Like maybe you try to reach a deal where you extend the ACA subsidies and do site-neutral reform and do 340B reform.
Right.
I mean, I would love to see some across-the-aisle handshaking. But, again, I'm sympathetic to the idea they don't want to give the Republicans a win heading into the midterms and then possibly blow their chance at taking the midterms. So I get the politics of it. It's just, it's unfortunate.
Right.
That's
the politics of it.
Yeah,
the politics
that's what the founders wanted, right?
Correct. Yeah. Correct. Yeah, I guess so. It's remarkable that we've made it so far with given how the sausage is made. So, but yeah, the politics that you're right. You're absolutely right. The politics dictates that you don't want a deal. You want chaos, and So maybe you want chaos and you want things to look as bad as possible so that you can win. You can win the next election. So, well, we'll see. We'll see how it goes. So, all right, sir.
That we will.
Thanks so much. Great job. Thanks for all the hard work. I mean, it's impressive that you're able to pull stuff together so quickly and do such a great job in such a short fashion. So kudos to you, sir.
My pleasure. Happy to help wherever I can.
All right. See you next week, sir.
Thank you.